So we know that mutational load increases neoantigens, so that may increase immune response. But there's a second part of that, which is that if you have a tumor that has that increased mutational load, great. But as the tumor progresses and develops more resistance, it develops mechanisms of avoiding an immune response that are beyond a checkpoint inhibitor. These cancers stop bringing in immune cells. You know, they have a way of becoming less and less immune activating. So then they become more immunologically cold. So what we've learned is that treating cancers earlier makes a difference. We get much higher response rates in first line than later line. And if you look at tumors that have tumor infiltrating lymphocytes above the median, they seem to have a much higher response, particularly in the first line setting. And then the neoadjuvant data is very, very encouraging, showing these marked improvements in estimated pathologic complete response rate. So I think what we're learning is that, you know, it's not the same as giving chemo, where we see a response in the metastatic setting, so we try for approval there, and then we move it earlier. You know, we're doing this with all these drugs. But sometimes where we really may see the best response is very early, and we really need to get those drugs much earlier into that setting. We don't even know if post-neoadjuvant, you know, after somebody's had a poor response, had surgery, and the main tumor is gone. There's a study looking at pembrolizumab in that setting, but we don't know if it's optimal because the main tumor isn't there. So you may actually want to be doing it even earlier than that. So you're not having a great response, add the pembrolizumab before surgery. That to me seems like the optimal way to move forward.